Welcome to the ICOI lecture series. I'm Professor Luis Pimenta, a professor in the Division of Prosthodontics at the College of Dental Medicine at Columbia University in New York. As a statement for no conflict of interest, I declare that I have no financial or personal relationships that could inappropriately influence the content of this presentation. And all the clinical cases and patient-related information presented today have been conducted with full patient consent and authorization for educational and academic use. The topic of our presentation today is about precision and aesthetics for immediate implant placement on anterior zone. And the main objectives for this lecture is to understanding anatomical consideration in the anterior zone, understand patient selection criteria, mastering implant positioning and precision, optimizing immediate placement with different protocols, achieve ideal aesthetic outcomes, and managing complications and risk factors. To start, we need to understand that immediate implant placement in the anterior zone has evolved significantly over the past decades. Advancements in surgical techniques and prosthetic materials have allowed us to really advance this protocol and to put this in more frequently used in practice. And of course, for that, we need a deeper understanding of biological and aesthetic factors that can affect the final outcome of our clinical interventions. One of the alternatives that we have is the use of flapless surgical approach, also taking advantage of digital planning tools that are used to enhance precision. Also, develop the techniques for immediate provisionalization, preserving soft tissue architecture, and of course, improving the aesthetic outcome on the white and pink zone, and achieving superior aesthetic outcomes. However, if we go back in history, according to the first installation protocol for the modern dental implants proposed by Brandmark, it was recommended that implants should be surgically placed only after a period of healing of the alveolar socket after tooth extraction, so adequate remodeling and healing of the alveolar bone would occur to optimize osseointegration of the implant. However, there are also early reports of immediate placement of dental implants, like the Tübingen immediate implant clinical studies that was reported in 1978. It's important for us to understand, in terms of the physiology of the healing process of the bone, that alveolar process undergoes significant resorption and volume loss after extraction or tooth loss due to other reasons. So as soon as we have the loss of a tooth or the extraction of a tooth, as the alveolar socket starts remodeling, that will lead to some significant volume loss after the extraction. And one of the advantages, or one of the ideas of having the immediate implant placement, is that that could limit the resorptive process. And the early implant failure is due to inadequate osseointegration, and it needs to be bioactive surface treatment that may enhance osseointegration after the implant placement. So with the development of new dental implants with more bioactive surface for improving osseointegration, we can now use more and more frequently the technique for immediate implant placement, especially when considering the aesthetic zones. There are some advantages in terms of placement of implants in the alveolar socket right after the extraction. First, would reduce treatment time. decrease the number of surgical sessions, minimize post-extraction resorption of the alveolar bone, provide a positive psychological impact on the patient that would have immediately replacement of that missing tooth, and place the implant in an ideal axial position in relation to the tooth that once occupied that socket. So those are some of the good and positive aspects of placing implant immediately. However, there are some inherent disadvantages as well in terms of difficulty in achieving implant stability. It's critical and very important that we have to achieve primary stabilization once we are placing the implant immediately. If we cannot achieve implant stability, primary implant stability at the moment of the placement, we should abort the process for immediate provisionalization and then go for the traditional approach of the implant placement. Also, we have a higher risk of implant failure according to the literature. However, most recent studies are showing very similar results. Unpredictable soft and hard tissue levels. However, with immediate provisionalization, we can better define the healing process of the hard and soft tissue, allowing a better aesthetic outcome when we achieve a good clinical outcome. And in most of the time, we need also to work with some additional bone graft when we are placing the implant immediately. The immediate insertion protocols and provisionalization concepts, as well as flapless surgery approach, may show reasonable aesthetic results with reduced treatment time, pain, and costs. In the extraction socket in the anterior maxilla, the main problem to overcome is the physiological height difference between the oral, interproximal, and facial bone and the respective soft tissue level. So it's very critical to understand that when we are working on the socket, the anatomy of that bone has different heights, and we need to take all of these heights into consideration. Since implants have a smaller diameter than the extracted teeth, the facial gaps are augmented with autogenous bone grafts. So when we are looking at the precise placement of the implant, when we are working on immediate implant placement, we need to understand that we cannot just follow the direct anatomy of the socket, because many times that will lead to a wrong position of the implant. Ideally, the immediate implant placement should be placed palatal in the socket, towards the palatal wall of the socket. And that will lead to a better position for the implant and consequently for the reconstruction and restorative process. Also, immediate implant placement in posterior tooth with conventional loading yields a predictable result in some complications. The most prominent complications were proximal contact loss, followed by loosening of the screw and cement debonding. And the implant survival rate was 96% at the mean time follow-up of 4 years and 9 months. That is when we're talking about immediate implant placement in the posterior zone. When a delayed implant placement protocol is applied, immediate or delayed loading demonstrates similar survival rate. And the heterogeneity of the data did not allow to draw any further conclusions in this study that was published recently. Immediate dental implant placed into infected sites presented a statistically significant higher risk of failures. So it's really critical when we're planning for immediate implant placement to make sure that we take into consideration whether or not the periapical area is infected, if there is any infection that needs to be treated previously before any implant placement. And peri-implant outcomes were not statistically affected in this intervention. In the literature nowadays, the available evidence supports the clinical efficacy of the early implant placement protocol. Early implant placement protocol results in implant outcomes similar to immediate delayed placement protocols and superior stability of peri-implant hard tissue compared to immediate implant placement. So when we're looking at the literature, most of the time, outcomes of early implant dental placement, when compared to implant placement protocols placed immediately, they have similar outcomes, and the results can be very positive for both protocols. Also, in this study by Osama El-Alabi, when he evaluated the pink static score for immediate implant placement, he noticed that immediately post-operatively, there was no statistically significant difference between the pink static score in the two groups. After 6 months, the study group, which is the immediate implant placement, showed a higher significantly median PES, pink static score, than the control group. And when he looked at the changes within each group in this study, there was a statistically significant increase in pink static score after 6 months, showing that the static outcomes with the immediate implant placement were significantly better. Now we're going to illustrate the sequence of a case demonstrating the immediate implant placement when we are using also digital planning and having the digital planning supporting the fabrication of a surgical stent and the immediate placement of the implant in a socket area and in a flapless situation position. So in this case, this patient came to our postgraduate prosthodontic clinic at Columbia University, and this case was conducted with our third-year resident, Dr. Nicholas Nowick. So to start this case, we decided to have evaluation using the CBCT to better determine the right position of the implants. And one of the challenges in this case was the gap, the space, the prosthetic space, because due to the diastema present and the missing teeth, the fabrication of a immediate provisionalization would be a challenge in terms of the distribution of the space. So here is how we plan the case in our software from TreeShape, study design. And here is when we do the intraoral scanning, and then we start fabricating or designing the provisionals. And then we plan, instead of having the extraction of the two teeth and the placement of the implants in both sockets, we decide to extract tooth number 10 and place the implant on number 10, graft the socket on tooth number 9, and place another implant on tooth number 8 with a flapless approach. And this is what you're observing now. So for planning the case, we uploaded not only the CBCT, but also we uploaded the intraoral scanner, and then we merged the two files combined in a way that we could have a better planning, taking into consideration not only the bone, but the soft tissue and the structure of the teeth in the mouth to achieve a better aesthetic outcome. So in this sequence, what you're seeing now is that we have the intraoral scanners with the prototype of the provisional fixed bridge, and the planning for the 2 implants on the bone at the CBCT. And with that, we can look precisely at the inclination and everything else to the point that we can achieve a better planning for our implant placement. With that in mind, now we're going to move forward and develop the surgical stent, fabricate the surgical stent, following that digital planning. On our digital planning, we plan for implants on tooth number 10 and number 8, and grafting the socket where the tooth number 9 would be extracted. So on the day of the procedure, we move forward with the extraction of tooth number 9 and number 10. And as I said, on tooth number 10, we will graft the socket. And on tooth number 9, we'll graft the socket. On tooth number 10, we'll place the implant. And the other implant will be placed in a flapless approach on the area of tooth number 8. Also, at the time that we were planning this case, we also developed a matrix or a stent that would allow us to better align the provisional prosthesis once the implants were placed. So this stent was made following the design of the posterior prosthesis, the temporary prosthesis on the anterior segment, and that will allow us to make sure that the clinical position of the provisional will be in the appropriate location for achieving the best aesthetic outcome. So at the moment of the surgery, first we position the surgical stent over the teeth. It's a tooth-supported surgical guide with a window here that we can certify that the stent is positioned precisely over the teeth to assure the stability of our surgical stent. Once the surgical stent is placed, then we'll proceed with the drilling process for the implant placement. In this case, we use the Straumann system, 3.3 millimeters diameter implant. So then the bars being used for the drills being used for the implant placement. Once the drills were used, we checked how the depth of the implant, which is 10 millimeters in this case. And with that, we plan to place the implant at least 1.5 to 2 millimeters below the bone crest to achieve a better aesthetic outcome later on. And then the implant is being placed at the site. And here is the implant placed on site number 10. For site number 9, as I said, we will graft the site on tooth number 9. And for tooth number 8, we came with a flapless approach that we mark with a puncher, the soft tissue puncher. And then we remove that tissue from the area. Here you can appreciate the removal of the soft tissue. And then we proceed with the sequence of drills for the implant placement on the site of tooth number 8 as well. Once the drills were used, we also check for the depth of the implant, and then we proceed with the implant placement of the implant on site number 8 up to the moment that we achieve primary stabilization. In this case, we achieve primary stabilization with 40 newtons per centimeter. On this image, you can appreciate the 2 implant placed, the socket on number 9, and subsequently with the grafting on the site of tooth number 10 on the buccal, and the socket grafting on the entire socket of tooth number 9. Then we take the X-rays to confirm the appropriate location of the implants. And at this moment, we will move forward for the provisionalization. For that, we have to get the provisional cylinders, attach the provisional cylinders to the implants, and then using that surgical or the provisional stent, we position the stent with the provisional in place to assure that we have the appropriate alignment of the provisional with the remaining teeth. Once the provisional is in place, we fill it out with acrylic, and then we finish the cervical area of our provisional, making sure that we have a concave buccal area for our immediate provisional placement to give space for our soft tissue growth. And here we have the immediate result before and right after the immediate placement of the implant. Of course, we have checked the occlusion, no contacts were noticed, and the patient was advised to have soft diet throughout the entire healing process that takes about 3 months, 3 to 4 months. And here we can appreciate 2 weeks after the implant placement, how the soft tissue is healing and how the provisionals are with the healing of the gingival tissue here surrounding the area of the implants and the site of tooth number 9, where we had the soft graft. And here you can once more appreciate how that the aesthetic achievement of this case with a better alignment of the teeth and a better smile for a patient. Now, as a sequence, we're going to have another case of immediate implant placement with a new implant system, the N1 implant system from Nobel Biocare. So the first case that we illustrated, we showed a case using the Straumann system. Now we're going to illustrate one showing the Nobel system, N1 dental implant. This next generation or new generation of dental implant, according to the literature, result in an atraumatic site preparation, enhanced osteogenesis, and present remarkable soft tissue maintenance. It's basically the implant placement is a sequence of 3 steps. We have to use the osteodirector, the osteoshaper, and then the immediate the implant placement. Here's the sequence. So we have the osteodirect or the osteodirector that is placed, and you can define how long is going to be your implant from 7 millimeters to 17 millimeters. Then we go and use the osteoshape or osteoshaper with a speed of 50 RPMs with an ideal torque of around 40 millimeters, 30 to 40 millimeters. And then in cases that you have a harder or more dense cortical bone, you have to use osteoshaper number 2 that will better prepare the site for the implant placement. But this is not something that you use very frequently. Most of the time, especially working on the maxilla, we just use the osteodirector and the osteoshaper, and then the immediate implant placement. Here is a sequence illustrating how we can use this in a protocol that is a step 1, step 2, and step 3. And according to the literature, this tri-oval shape of the implant can reduce cortical stress compared to round implants and enhance also primary stabilization and according to the literature, result also in faster secondary stability. This tri-oval shape of the implant also result in minimal bone remodeling from implant loading to 1 year follow-up, high implant survival rate indicating successful osseo integration, allows implant placement after 2 steps at most of the implant sites, and wide versatility of the novel concept system that we also have an intermediate abutment. So this is a video just illustrating the sequence, how you place the implant in 3 steps. The first step is the osseo director that you're gonna use in the bone, and you precisely position and go to the depth that you are planning for your implant. And then subsequently, you go for the osseo, once you go for the osseo director that can go to speeds up to 2000 RPMs. Normally, we recommend about 1200 RPM. We go for the second sequence, which is the osseo shaper. And the osseo shaper is where you're gonna define the precise shape of your socket for the implant placement. On this osseo shaper, the recommendation is to use about 50 RPM for the osteotomy, and the torque can be ranging from 30 to 40 newtons per centimeter. So you make the adjustment on your motor, implant motor, and then you go and you place your implant with around 50 RPM and the torque around 40 newtons per centimeter. And here is the sequence illustrating the video illustrating the implant placement. Once you have that implant placed, you can manually use the wrench to finish the torque to achieve your primary stabilization and to define the depth of your implant placement that most of the time we recommend 1.5 to 2 millimeters below the bone crest. Once you have that implant placed, we have different connections for the prosthetic reconstruction. And on this specifically sequence, we are using the end base. The end base is placed right after the immediate implant placement, and then all the provisionalization is going to be above that bone integration level. So that is one of the advantages. Once you have the end base placed, you will never remove the end base anymore, and you're going to be working on the soft tissue level, not at the bone level. And here's a video illustrating how we place the implant in that site. And here we have the 2 weeks after provisionalization. It's important to understand, as I said, when we are sequencing the placement of immediate implants, that we have to use the drills towards the palatal wall of the socket to make sure that we'll have the appropriate direction of our implant. And this is an illustration that we have in the ICOI library showing the sequence of the implant placement with the immediate sequence. And then we have the abutment placed immediately and consequently the provisional or the final prosthesis. And that will allow the healing of the soft tissue and to preserve the bone. And this is what illustrates what happens in 6 months, that we have the remodeling of the bone crest, and that is the appropriate reconstruction of the soft and hard tissue healing once the immediate implant is placed. Now we're going to illustrate another video. This is another video illustrating the full sequence in high speed from the extraction up to the provisionalization. So we start by doing the syndesmectomy for removing the fibers and detaching the fibers from the root surface that will be extracted. So we start doing the syndesmectomy, and that is to allow us to have an easier process for the extraction with an atraumatic extraction of the root. Once we have the syndesmectomy completed, we're going to go with the elevator using the elevator. And once we have completed the elevation of the tooth, we're going to extract the tooth with the forceps. Once the tooth is extracted, we're going to clean the socket with a curette and irrigation to make sure that we have a clean socket and that we have the appropriate site. In this case, we start with the first drill to direct. Keep in mind that we always go towards the palatal wall of the socket to direct. Also, we have to keep in mind that we can use this dot here in our handpiece to make sure where the direction of the implant will be, especially when we're planning for the prosthetic reconstruction. Once we have the drilling process completed, we check the depth of the drilling to make sure that we are in the appropriate depth for the implant placement, And then we go and we place the implant up to the moment that we achieve primary stabilization. And then we move with our manual wrench to make sure that we have the final torque to achieve the primary stabilization and to position properly the implant 2 millimeters below the bone crest. Once the implant is placed, we position the cylinder, the temporary cylinder. And with this clear matrix, we fill out the matrix with flowable composite resin, making sure that we have a wood stick to prevent the material to go and interfere with the screw of our provisional cylinder. Once we have our provisional filled out, we're going to remove that stick, the wood stick, to get access to the cylinder, to the screw. And we're going to unscrew the provisional and finish the provisional with rotatory instruments and polish it, redefining the emergency profile. At this moment, we remove the provisional. In this case, we're now going and adjusting and making sure that we have no contact on the palatal with the opposing arch. So this is critical that we have to not have any load, immediate load on those implants. We're talking about immediate provisionalization, but not immediate load. Redefining the buccal contour as well. Checking occlusion to make sure that there's no contact in centric or excursive movements. And we slightly reduce the incisal edge to avoid any contact on excursion as well. And here you can appreciate the immediate provisionalization on this case. Here we have one more case that we're planning on the CBCT, and then in this case, the tooth had a fracture, a longitudinal fracture. So we're going to extract the tooth. Same process with the syndesmectomy. That will detach the fibers, the periodontal ligament, from the root, from the cementum and the root. Then we will atraumatically extract the tooth using the forceps with some rotation in the movement of rotation, and then we'll pull out the tooth. The socket shows no signs of any trauma in the area. And then we're going to clean the socket with a curette, making sure that we remove any possible contamination or sites with some fibers and everything and all the components that are in the socket. Initiating the placement of the implant with the first drill, always supported by the palatal surface of the socket. Here you can appreciate exactly where the drill worked in the palatal surface. That will assure a precise position of our implant and allowing access to the screw once we have the prosthetic temporary provisional crown. In this case, we also use the N1 system. And this is the osseo shaper. So we use the osseo director first. Now we go with the osseo shaper. And once we complete the drilling with the osseo shaper, we'll place the implant. Implant being placed with 50 RPM and final torque between 30 and 40 newtons per centimeter. Once the implant is placed, we will finish the torque with the manual wrench. Making sure that we have up to 40 Newton centimeter. Once the implant is placed, we are now attaching the N base, the M1 base. This is the N1 base that is attached manually and digitally, like finger torque. And over the N1 base, we'll position the cylinder. In this moment, now we'll need to make some adjustments on the temporary cylinder to make sure that we have the appropriate height. And once we have the cylinder placed, we're going to graft the buccal area of the socket to make sure that we have the appropriate bone volume on the socket. to facilitate the placement of the grafting, the granulated bone, we use the periodontal probe to start packing and positioning the bone on the buccal. And as we are going to make the adjustment of the cylinder to avoid any debris to contaminate the area, we protect that with a Teflon tape. We normally use two layers of Teflon tape to protect the area. And we're going to work with a high speed to adjust the size of the temporary cylinder. Once the adjustment is completed, we'll protect the entrance of the channel for the screw with a wood stick. We're going to position the silicone clear matrix, and we will fill out that silicone clear matrix that was fabricated based on the wax up that we had for the initial case and light cure the material. Once it's completed, we remove the matrix, we start finishing and polishing, and here we have the final result of the immediate provisional crown. And here is the radiographic aspect of the final. Here are some of the take-home messages about immediate dental implant placement after tooth extraction. A viable and effective clinical procedure that presents high success and survival rates comparable to conventional delayed implant placement. Immediate dental implants are predictable in terms of osseointegration when proper protocols are followed. Primary stability at the time of placement is critical to ensure successful osseointegration and long-term implant survival. Also, immediate dental implant placement is an advantage in the anterior maxilla because it preserves the gingival architecture, soft tissue contours, and emergence profile, providing superior aesthetics results compared to delayed protocols. Also, immediate dental implant placement reduces the overall treatment time, eliminating the need for secondary surgical procedure and shortening the time to final restoration. Also, immediate dental implant placement preserves the alveolar ridge and minimizes bone resorption following tooth extraction. The use of bone graft materials into the gap between the implant and the extraction socket further enhances rigid preservation and supports long-term stability. And adhering to precise surgical and prosthetic protocols, atraumatic extraction techniques, appropriate implant positioning, and the use of immediate provisional restorations when indicated. And so successful outcomes are dependent on meticulous case selection, patient's systemic health, anatomical site conditions, for example, bone volume and quality, and the absence of active infection in the time of the extraction. Overall, immediate implant placement is a highly effective and efficient approach to tooth replacement in suitable cases. It offers excellent functional and aesthetic results with reduced treatment duration.